Hi. Thank you so much for joining us for our first Facebook Live Ask a Cardiologist. We're excited to be streaming from the Inova Heart and Vascular Institute in Falls Church, Virginia. I'm Dr. Chuck Murphy, your host, and I'm joined by Kelly Epps, Dr. Kelly Epps, and we're going to be talking about heart health, signs and symptoms of heart disease, risk factors, and much more. One of the main things we'll be doing is answering some of your questions. So please ask your questions in the comment section, and we will try to answer them as we go through this program. Please remember that our answers are meant for informational purposes only and are not intended to be providing individualized medical advice, which you should get from your physician. As I said, I'm Dr. Chuck Murphy. I am the Chief Safety Officer at the Inova Heart and Vascular Institute and Medical Director of the Cardiovascular ICU, and I'm joined by Dr. Kelly Epps. Kelly, would you like to introduce yourself, please?
Sure. Thank you, Chuck. I am Kelly Epps. I'm an interventional cardiologist here at Inova Heart and Vascular Institute, and I'm also the Medical Director of Inova Women's Cardiovascular Health Center.
Great. And tell us a little bit about your training, Kelly.
Sure. I trained at Harvard for medical school, and then after that I went on to complete my residency at the Johns Hopkins Hospital, and then I went on to complete a fellowship in cardiology and interventional cardiology at the University of Pennsylvania, where I also completed a Master's of Science in Health Policy Research, specifically focusing on outcomes of cardiovascular procedures in women.
Yeah, and tell us about heart disease in women. Let us know what a significant problem that is.
Sure. So heart disease is the #1 killer of both men and women. And unfortunately, tends to be a lack of awareness of how important it is for women to know about their cardiovascular risk factors and their cardiovascular health, because indeed it is our #1 health concern.
Okay. And then why don't we just take a couple minutes to discuss signs and symptoms of heart disease, both in men and in women.
Sure. The most common symptom in both men and women tends to be chest pain or pressure in the middle of the chest. But we know that there can be other symptoms of heart disease, and it's particularly important for women to know that, because women are more likely to present with more subtle symptoms of heart disease. So they may present with symptoms like shortness of breath, with fatigue or weakness, and these are symptoms that could easily be missed.
Okay, and from my experience, I know that the chest pain that sometimes is particularly worrisome to me is chest pain that then radiates down an arm, or chest pain that radiates to the neck, or chest pain that radiates through to the back, are particularly worrisome in terms of things. And then I would also say that, some people actually will have pain in the upper abdomen, and one should not assume that may not be related to your heart. And so also we're going to talk about risk factors. I noticed that several of our questions that are coming through are about risk factors, and we talk about what are modifiable risk factors, or things that you can do something about. And included amongst those are your blood pressure, your cholesterol, whether you smoke or not. Obviously, you can't control if you're diabetic, but in terms of managing your diabetes and making sure that your diabetes is in good control, and then exercise and diet are two of the other modifiable risk factors, as opposed to your age and your family history, which are not modifiable, or you can't do something about. So I want to dive right into our questions. And one of our questions is about blood pressure. And Kelly, maybe you could just start generally talking about blood pressure management, high blood pressure, and what the current thinking about blood pressure control is.
Sure, absolutely. So there's been a lot of questions about blood pressure lately, and that's in particular because we have new blood pressure guidelines in the past year and a half or so, where we used to diagnose high blood pressure was any blood pressure greater than 140/90. That threshold has now been lowered. So high blood pressure is considered any blood pressure greater than 130/80. So we have many more patients now who actually carry a diagnosis of high blood pressure.
Okay. And then one of our questions is from a 45-year-old African-American woman who notes that her cholesterol is high. It's 390. I will say she's asking about drugs and dose, and we're not going to get that specific, but could you comment about cholesterol and management of cholesterol?
Absolutely. So cholesterol is very important for you to know your numbers and know your level. There's a total cholesterol level that's drawn, a blood draw, but we also look at components of cholesterol as well. We look at LDL, which is considered the bad cholesterol. That's the cholesterol we worry about because it is more likely to build up plaque in the arteries and cause blockages. And then there's HDL, which is the good cholesterol. That's the cholesterol that tends to remove cholesterol from the arteries and processes them in the liver so we can get rid of that cholesterol. So we have to look at what those ratios are as well and what the total cholesterol is. But for our audience who asked about a cholesterol of 390, that is actually very high total cholesterol. And generally we think that is even in a range where it may be some genetic component to that. And we think about being aggressive about medications, not just pills, but there are also some newer injectable medications that we use to treat family patients who we think have a familial component to their high cholesterol.
And where would I generally want to see my LDL be below?
Mm-hmm. So LDL less than 100 is considered normal. In patients who have other risk factors or actually have a diagnosis of heart disease or stroke in the past, even we want to see cholesterol even lower than that. So LDL less than 70 in those patients.
Okay, thank you, Kelly. And one of our questions is about calcium scores, and it's a 50-year-old gentleman, has hypertension and a high cholesterol and a family history of coronary disease, and they're wondering about when they should think about getting a calcium score test.
Sure, absolutely. So when we build up plaque in the heart arteries, that tends to happen over time, and over time the plaque can become very calcified and harden. It's what we think of as hardened arteries. And there are ways, though, that we can detect that calcium buildup in the arteries even before patients have symptoms of heart disease. That's the coronary score, the coronary calcium scan. And so that test may give us a sense of how aggressive we should be in terms of medications and treatments for a patient, and also may give patients a sense of how they should modify their lifestyle to try to address the fact that they are already starting to build up this calcium in their heart arteries.
Okay, great. And one of our questions actually is about your medical practice, because the viewer actually is, I think, doing a good job of educating themselves, and has noted that you've received a distinction as one of the top interventional cardiologists in the Washington area, but wonders about whether you see other types of patients as well. So maybe you could talk about your practice and what patients you see.
Sure. So I am an interventional cardiologist, so that means I specialize in procedures specifically on the heart arteries and also some procedures on heart valves. But I see many patients with heart disease. It doesn't necessarily need to be patients who just need heart procedures. I see many patients for general cardiology issues, for preventative cardiology issues. I see a lot of women in my clinic because that's a specific area of interest for me. I see patients who have family history and just want to know what their risk is. I have patients who've been treated for breast cancer in the past, and we know that breast cancer can increase your risk of heart disease in the future, and so they come to me to talk about what that risk is like. I see many patients who have had pregnancy issues and also have issues concerning the heart related to pregnancy. So my practice is quite broad.
Okay, and actually you touched on cardio-oncology, and really the practice of cardiology around the treatment of cancers, and I think that's an important topic, and unfortunately some of the medications that are used to treat cancers unfortunately have deleterious effects on the heart, and so I think you're partnering with our cancer center, and that is a specific area?
Correct. So our Inova Cancer Institute takes care of all of our cancer patients, and particularly our breast cancer population. We know that some of the medications that we use to target their cancer and their life-saving treatments for them, whether it's chemotherapy, whether it's radiation, we know can impact the heart long term. It can impact heart function. It can increase their risk for coronary artery disease or valve disease. And so we're really partnering with the oncology center so that we can have the best outcomes we can in those patients, because we know for long-term survival, cardiovascular health is very important for patients with cancer as well.
And I see here a question about switching topics of family history. And there's one of our listeners or watchers that their parents had heart disease, and so they're wondering about the impact that that has on their risk of having cardiac disease. So can you talk about family history
Sure.
and how that should perhaps change our viewers, what their approach is about this?
And I'm glad that question was asked, because I know when we first started, you talked about modifiable factors and non-modifiable factors. And while genetics is a non-modifiable risk factor, it's something that we're born with, we do know that there's plenty that you can do to help modify that risk, because genetics is so important in cardiovascular disease. We know that patients who have a family history, particularly of premature heart disease, that would be in a woman who develops heart disease before the age of 65, a man who develops it before the age of 55, we know that there is a strong genetic link there, and that if you have that in your family history, that you are at higher risk than someone who does not have that in their family history. And so it's really important for you to know that, for your doctor to know what your family history is, because it may impact what tests they run on you, and also it may impact the advice that you're given in terms of treatment and how aggressive we are about reducing your risk factors, and in making sure that we have good lifestyle interventions to manage weight, increasing exercise as well.
Okay, all right. And the next question from our viewers is around screening tests. So we have a 50-year-old gentleman who's going to be having elective orthopedic surgery, and they're wondering about the need for any screening tests before they have surgery.
Right.
And I think that's a great question.
As a surgeon, I know you do. So before anyone undergoes a surgical procedure, the question is the heart strong enough to undergo a surgical procedure? And so some of that depends on what is the risk of the surgery. Is it a low-risk surgery, or is it a higher risk surgery? But we also look at patient factors as well. And so going into surgery, generally what I want to know is, does a patient have any symptoms that could be related to cardiovascular disease that they're concerned about, that may make me say, let's do some testing to make sure the heart is nice and strong before you go into a surgery. And some of those tests may be things like just a routine EKG to make sure the EKG is okay. But also sometimes we even order stress tests or echocardiograms to make sure that the heart function and structure and that the blood flow to the heart is good before going into a surgery. Not every patient needs that, so it's very important for you to talk to your primary care physician about whether or not this is a type of testing that you need or an evaluation that you need before surgery. But we certainly take heart health seriously going into a surgery.
Yeah, I think that's great. And running through my mind at the same time was that certainly talking to your surgeon about this in advance. This is an excellent type of question to ask, and as a surgeon, and all surgeons are very cognizant, very aware of these issues and such. So great question once again. So the next question is around exercise, and maybe you could just talk about the current recommendations around exercise.
Absolutely. So currently, for ideal cardiovascular health, the exercise recommendation is that patients exercise 30 to 45 minutes most days of the week to help maintain cardiovascular health. And for patients who are trying to lose weight, the recommendation is even higher. So it's 60 to 8, maybe even 75 minutes most days of the week. So it really does incorporate a fair amount of activity as the recommendation, because we know that sedentary lifestyle really is associated with higher risk of heart disease.
Okay. I'm going to mention that we have a question here about atrial flutter and ablations. It's a great question. I think that stay tuned, because I think in the near future, I would hope that we will have a Facebook Live with a specialist in that area to answer the specific questions about atrial fibrillation, atrial flutter, ablations, et cetera. So great question, but we're not going to sort of answer that one today. There's a question here about aspirin, and I think some of the thinking around aspirin is changing. There's some recent information that's come out. So Kelly, maybe you could touch on the current thinking about aspirin in older individuals in terms of using it for prevention.
Mm-hmm. So when we talk about prescribing aspirin for a patient to reduce your risk of heart disease, or to reduce your risk, I should say, of a heart attack or a stroke, that's for a preventative purpose. For patients who've never had any form of heart event before in the past, or stroke, then it's primary prevention. So the question is, how important is aspirin for primary prevention? And we used to think that in certain patients, especially patients who were higher risk and had a lot of risk factors, that aspirin was a good medication for prevention. But what we're realizing is that there are downsides to aspirin as well, and that in some patients aspirin can be dangerous, particularly related to increasing the risk of bleeding, particularly gastrointestinal bleeding. And so there have been studies that have done more recently that have looked at older patients, so patients 70 years old or greater, and it looks like the risk of bleeding may be higher in those patients than actually the risk of a heart attack or stroke. And the thinking has shifted a bit that in certain patients we probably shouldn't be as aggressive as we are about aspirin. Now that's for patients who've never had heart events. So many of the patients who I see in clinic who've had heart attacks or strokes before, they should most likely be on an aspirin, and that's a decision that patient should make with their doctor. But for patients who've never had any heart events before, the thinking on aspirin has shifted a little bit.
Okay, great. And I think there's a really good question here about someone that has high blood pressure and a high cholesterol, and they're on medications to treat those, and they're wondering whether they need to see a cardiologist as part of the rotation of physicians that they see.
Mm-hmm. So cardiologists certainly see patients for risk factor management alone, for things like high blood pressure and cholesterol. What I would say is some primary care doctors are very comfortable managing that, and if it's well controlled with what we would consider our usual starting line medications, a primary care doctor may feel very comfortable managing it. Sometimes you may get to the point where primary care doctor feels like other steps are needed and it's important to see a cardiologist, or anytime you're concerned about your personal risk, especially if you have risk factors plus family history, it's never the wrong thing to see a cardiologist if you have any questions or concerns for them.
Okay. And then there is a question here about one of our viewers has had a heart attack, unfortunately, in the past, but they're wondering about the importance of being in a cardiac rehab program. Mm-hmm. Maybe you could touch on the importance of being in that type of program after you have a cardiac event?
Sure, absolutely. So cardiac rehab is very important after you've had any type of heart event like a heart attack, or anytime you've had valve surgery, or if you've had coronary artery bypass graft surgery. Cardiac rehab is where you come in, and we have one here at Inova Heart and Vascular Institute, where you exercise with an exercise therapist. There's nurses that monitor you, and they come up with an exercise program for you and try to build up your exercise capacity and stamina as you're recovering from your heart event. We know that patients who complete cardiac rehab, that they do much better long term than patients who do not complete the full 3 months of cardiac rehab, because there's also, in addition to exercise therapy, there's education about lifestyle modification, about diet that can be really helpful moving forward long term. We do know that women are under-referred for cardiac rehab, and it's very important for them to know as well that this is a treatment option for them.
Okay, and I see here a question about severe tricuspid regurgitation, and they're looking for a heart surgeon. And I would say here that we certainly do that type of surgery here at Inova Heart and Vascular Institute, and we actually have several surgeons that would commonly do those procedures. And so, I think that will be my answer for that specific question. I think in sort of closing here, I think there's some important things for our viewers to do. One is to know your numbers. Be aware of what your blood pressure is. Particularly if you have the family history, et cetera. We want to make sure that you know your blood pressure, that you know what your cholesterol numbers are, if it's appropriate. We want you to make sure and pay attention to the symptoms that we talked about, that Dr. Epps was talking about. So if you're having chest pain when you're exerting yourself or shortness of breath. Don't bury your head in the sand, but pay attention to your body and the symptoms that you're having. And then also, I think one of the important messages is to be proactive. It's one of the things I know is that back in the Korean War, they would see these plaque, the buildup, even in patients that were in their 20s. So that you really do need to start early on paying attention to your diet and your exercise, and so I would say to think about those things early on. Dr. Epps, what other things would you like to add?
I think I would add also just in being proactive is don't be afraid to talk to your doctor. If you're having any symptoms, any questions or concerns, a lot of times we try to explain away our symptoms. I think it's important to talk to your doctor. There are great resources on the internet. If you have any questions, Inova.org is a resource for you. Also, the American Heart Association has a website that has a lot of information about how to manage your cardiovascular risks. So I think there are certainly resources out there, and then also having a good relationship with your doctor so you can talk about any signs or symptoms that come up that you're concerned about.
And I think that's a great point about the web, and to make certain that you trust where the site that you're looking at, because there is a lot of information on the web, but you really do want to go to a trusted site where you're going to get reliable information. So I think that that's important as well. I do want to mention that next week, February 22nd, we're actually going to have another Facebook Live with Dr. Sarin and Dr. Sherwood, who are two of our physicians that are on what's called our structural heart team, that are doing what's called TAVR as one example, where they're doing these valve replacements literally through an artery in the groin, which is one of the exciting advances in cardiology over the last couple decades, I think. And so that's going to be a great show, and I encourage our audience to tune in for that. I think it'll be very informative for them. So thanks so much for your time and interest. Thank you for those that sent in questions. We really appreciate it, and we certainly wish you the best moving forward. Thanks so much.
Thank you.